Good afternoon, friends. It's wonderful to be here and participate in this great conference. And I thank the organizers for giving me this opportunity to discuss with you on this topic of target blood pressure in diabetic nephropathy. As far as controversy is concerned, I don't think this is going to be a big controversy. And I'm sure after the discussion for the next 15 minutes, you will agree with me that there is no big controversy about what should be the target blood pressure in diabetic nephropathy. Of course, all of us know that hypertension is a very significant CV and renal risk factor. You know, when hypertension is left uncontrolled, we are really worried about the so many side effects and the complications that they take place. Amongst them, the most important is coronary artery disease, cardiovascular complications, and stroke is the highest you find amongst the hypertensives if they go uncontrolled, and renal disease is one of them. So these are all important aspects that we have to consider so that we control hypertension properly. We also know, as I mentioned, hypertension increases the risk of cardiovascular mortality and also morbidity. You see the difference between the normotensives and hypertensives, how the incidence is higher amongst people who have uncontrolled blood pressure. And it's very clearly demonstrated over the last many decades that how treating hypertension would reduce the cardiovascular morbidity as well as mortality, as it's depicted in one of the slides here. And now when we also talk about diabetes, high risk of cardiovascular events are, as it is there in uncontrolled, metabolically uncontrolled type 2 diabetes, whether they have hypertension or not. These three aspects again, like stroke, myocardial infarction and cardiovascular. So my predecessor has been discussing about the incidence of myocardial infarction, how we prevent it. We must also understand proteinuria is also an independent risk factor to predict strokes and cardiovascular events in the type 2 diabetes. This is whether they have hypertension or not. The proteinuria along with the diabetes itself is a risk factor. Now when coming to the topic of diabetic nephropathy, we must realize that diabetic nephropathy is the leading cause of kidney disease. When I say this, I mean amongst all other conditions, this would be the most important and also an important cause. So it is generally defined by the increased urinary albumin excretion in the absence of other renal disease. It's a very simplified definition. So whenever there is urinary albumin excretion, and so there is a certain element of renal disease in these patients, we can further stage nephropathy. It can be a simple albuminuria, or it can be another staging where patient has increased creatinine, they have increased eGFR levels and high proteinuria. So to start with, screening for microalbuminuria should be performed at the diagnosis and later every year in type 2 diabetics. On an average, we know the type 2 diabetics develop this kind of nephropathy about 10 years after the onset of diabetes. In case of type 1 diabetics, we have to be more careful because the incidence is higher amongst these people, and we need to screen them for microalbumin right from after the age of 5 years after the onset of diabetes. And what are the risk factors for diabetic nephropathy? We know that many diabetes would develop diabetic nephropathy in course of time, but when they have metabolically uncontrolled diabetes, it's very obvious to us that their chances are high. And whenever they have hypertension, the chances are high to develop nephropathy. And there are certain people who are genetically predisposed. We always see these people among some families where they have higher incidence of nephropathy amongst these diabetics, irrespective of their metabolic control. So the genetic predisposition always plays an important role. And of course, we should also remember that abnormal lipids and smoking can be another risk factor for these diabetics who can develop nephropathy. Many studies have also shown that people who consume high quantity of animal proteins in certain societies and countries, it has been found that the incidence of diabetic nephropathy is high. So hypertension in diabetic nephropathy is the one which we are discussing. So careful blood pressure control is needed to prevent the progression of diabetic nephropathy. and also other complications that I've been mentioning. UKPDS study, I'm sure you're all aware, one of the very landmark studies done long back on type 2 diabetic patients. It's a huge study where they have found out there's a 12% reduction in diabetic complication with each 10% reduction in the systolic blood pressure, which is a very significant point to be noticed by us. It has been said that blood pressure control is even more important when you're dealing with the diabetic nephropathy than even glycemic control. Randomly, when you look at it, it looks like a controversial statement, but the recent data suggests that more attention has to be paid to controlling the risk factors such as hypertension and lipids in diabetic patients, apart from the metabolic control, of course. And UKPDS has actually looked at the difference between glycemic control and blood pressure control, and it has reported that blood pressure control is more important because this is a study where they have found out the incidence of complications being higher in the people who have uncontrolled hypertension in spite of their diabetic control. So when it comes to management of hypertension in diabetic nephropathy, in general, antihypertensive therapy, irrespective of whatever agent we give, definitely has some positive effect on the reduction in the progression of the glomerulopathy. But we all know that ACE inhibitors are very clearly shown to delay the development of diabetic nephropathy in people with microalbuminuria. We are not talking about people with diabetic nephropathy. Even people who have microalbuminuria, I am sure this elite audience know the role of ACE inhibitors in postponing diabetic nephropathy in these people. So continuing about ACE inhibitors and ARBs in treating diabetic nephropathy. So both of them reduce blood pressure and albuminuria and protect kidney function in patients with hypertension and nephropathy. We're talking about diabetic nephropathy. In addition to the beneficial CV effects, they are also shown to have beneficial effects on the progression of retinopathy, which is a very important thing when you're dealing with diabetic hypertensive, because microvascular complications are very high in these people, and retinopathy is one of the fears that we have when we are dealing with the people. So of course, achieving good metabolic control, treating hypertension, I mentioned here, treating hypertension, keeping the blood pressure at 130 or 80 or less, and using drugs with blocking effect on renin, angiotensin, aldosterone system, and treating dyslipidemias also. These are the effective ways to delay the progression to the more advanced stage of nephropathy, and by doing that we reduce the mortality and also the morbidity. We all know that hypertension and diabetes is a bad combination, and if we are dealing with hypertension with diabetic nephropathy, it can be even worse. We know that. So diabetic hypertensives are more likely to have microalbuminuria, and they are more likely to have impaired renal function, which we have actually talked about it. This is one of the hypertension optimal treatment studies. This is also one of the landmark studies where they have very clearly shown that intensive blood pressure lowering decreases cardiovascular risk in patients with hypertension, especially those with diabetes, compared to non-diabetics. Very strict control of blood pressure definitely reduces. As you see the reduction in the blood pressure, there is a definite reduction in the complications. UKPDS, as I just mentioned, one of the very large studies done on type 2 diabetics in UK. So they have looked at relative risk reduction with tight versus less tight blood pressure control. So tight blood pressure control decreases the mortality and morbidity in patients with diabetes. Time and again it has been proved. And this is one of the very big studies done on a large number of type 2 diabetic patients where they have found out a significant reduction in some of these major complications like strokes, microvascular disease, and visual acuity, diabetes related deaths in general, and so on. So diabetic hypertensives, when we talk about microalbuminuria, this is an integrated marker of cardiovascular and renal. You know, this is almost like a clinical marker. When somebody has a microalbuminuria, that means he already has some microvascular complication. And diabetes and hypertension, along with increased urinary albumin excretion, has increased risk of CB events. Obviously, their renal function is going to decline over the time, and strict blood pressure control reduces albuminuria, and it also inhibits the further damage of the renal function. So when it comes to choice of antihypertensives, there are many drugs that are available, but we are obviously focused more on ACE inhibitors and ARBs. Drugs that seem to have special benefit in diabetes, however, are ACEs and also ARBs. Actually, we are all familiar with most of these antihypertensives. On our daily basis, we use them treating hypertension. So when it comes to diabetes, also apart from the ACE inhibitors and ARBs, we need to use one of these drugs. You also know that usually most of these people require more than one drug to control hypertension, because you want to control a very strict control of hypertension, bring it down to below 130 by 80. The diabetics have a role to play because they reduce the fluid volume, but also we have to look at some of the drawbacks that they can have, electrolyte imbalance, or they can even increase sometimes the levels of lipids and uric acid. We need to look at them. Beta blockers, of course, atenolol is no more a favorite drug amongst the clinicians, but sometimes we do need to use a beta blocker in treating diabetic hypertensives when there is a specific need to use them. For example, like a coronary artery disease. Calcium channel blockers are always added when there are some newer calcium channel blockers which are supposed to have even better effect than the age-old amlodipine. And coming back to ACE inhibitors and ARBs, they ensure better renal protection, and they have to be an integral part of treating hypertension in diabetic nephropathy. ACE inhibitors and ARBs have nephroprotective effect, and it is independent of their antihypertensive activity, and they have shown that they can delay or slow the progression of nephropathy. And continuing about the ARBs and ACEs, their treatment is reduce blood pressure and albuminuria and protect kidney functions in patients with nephropathy. In addition to beneficial CV effects, they also have beneficial effect on the progression of diabetic retinopathy, which I mentioned earlier. So the target blood pressure, it is recommended to lower the blood pressure to certainly 130 by 80 in all diabetic hypertensive patients to ensure optimum cardiovascular risk prevention, and so that they don't develop some of these deadly complications which they are already prone as diabetics. So ladies and gentlemen, I just wanted to be very brief and do not take much of your time, and only talk about these important aspects of target blood pressure and the agents to be used and why we should use. So there is certainly not much of controversy when we say that we have to treat diabetic hypertensives, particularly if they have nephropathy. We have to bring it down to below 130 by 80. And of course, we have to make sure that they do not go into hypertension, because some of these patients who have significant cardiovascular problems or other conditions, they will be put under high risk if they have very severe hypertension. I thank Chairperson and ladies and gentlemen for your patient hearing.